Okay, 6 o'clock, guys. We're gonna go ahead and get started. A couple things for the class. You guys know that you have a. Can you hear me now, Jennifer? There you are. Okay. You guys have a new study guide kind of up. Remember that these are just something that gets you guys some points on a board. Like if you miss a couple or what, because I make questions. I grab questions from the bank. Like as long as you're over 70. Which is past. I mean, that's all I care about. It's just something that gives you guys a grade that I can turn in, and that's all they are. You guys can take several chances to do it. I looked at the last one and I saw where 2 questions, like 2/3, if 3/4, you guys got them wrong. That's obviously a bad question, or we missed something. I'm trying to figure out how to go back in there and like take that question out. But as I learn the system, I can see like one question it just where almost everyone got it wrong. Well, that's not, that's a different issue than, just not knowing it. And then I'm trying to figure out how to take those out with overrides and stuff like that. But don't get too hung up on those. It's just stuff I throw in there. And what I'm going to do is look for emails from me. Like you guys have asked for study guides, other stuff I printed off. I'm going to try to email those out to you since I can't see everyone in class. That way you guys can print them off. And rather than you kind of go, oh man, what do I need to study? I'll try to give you more direct study guides so you know more directly what to study. The study guide that's up now, some of you guys have already got it done. I think it's due December 2nd at 8 o'clock. So please have it done by then if you don't have it done yet. So tonight's lecture is Airway. So now we've gone over kind of all the preparatory stuff, health and safety, all the way up to patient assessment. Now we're getting into the specific part. So you need to take these and apply them back to patient assessment. Take your anatomy, throw it in this, and you need to start adding those at least 2 or 3 chapters together to try to get a good comprehensive view of your patient, of what you need to do and why you're doing it. And we'll try to touch on some of that tonight, like with PEEP again, how to bag properly, because all of those things kind of all add up. You need to understand what you're doing. So again, tonight's airway management. So again, we've gone over this. We're going to take the anatomy, went over the principles, the equipment, and then how to properly manage that airway. One of the slides at one time said you guys need to become like masters or do a good job at patient assessment. You also need to become very competent, if not masters, at good basic airway management, like how to open an airway, how to suction it, how to put in an adjunct and use a BVM. Because if you don't master those, anything that you can do or want to do beyond that won't matter. So we're going to practice a lot and need to be really good at managing a basic airway. So we're going to touch on anatomy again, do a good airway assessment, which we've also talked about. And then the last part of the class is kind of the meat and potatoes of what you guys can do physically to open an airway or to manage it. I was able to throw a couple extra things in here, but I will try to stop. There's stuff that I know is on tests, like percentages of oxygen delivery devices, things like that. We'll try to stop, and I'll try to have you point these out on things that I know that I've seen on tests before. Okay, so what we're going to go through, and you guys, I've scheduled some of this for the next class, so if we don't get all the way through it, we're not going to go late tonight. In fact, I'm going to try to let you out early, and then we'll just pick this up. I've scheduled to pick this up next time. So we will not be going at least past 9 o'clock tonight. Okay, so the primary component of caring for a patient is ensuring that they can breathe adequately. And remember, like on your state tests, anything that you guys test on, it's always going to come back to your airway, your breathing, and your circulation. So again, I really encourage you, don't become a moth to a flame unless it's like arterial bleeding. That if you go into your state test, if you answer something on a test, everything, airway, breathing, and circulation needs to be taken care of first before you go down the line. And they will try to stump you on that principle. So always keep that in mind. So remember, we've talked about breathing is essentially, we shouldn't notice it with our patients or even with ourselves. But if we do, then there's a problem and we need to try to address it. And when that's disrupted for our patients, remember that's very scary. Not if you've ever had the wind knocked out of you or an asthma attack or something like that. It's very scary. It's scary for them, and then we need to try to immediately correct that for them. Okay, so when they can't breathe for whatever reason, they're not ventilating, or they don't have good respiration, then there's lots of stuff that's not happening there, which we'll go over detail later. But we need to try to fix it. So if they can't, like we're not getting oxygen down, we're not getting CO2 out. The organs are being perfused. We might be even, if it's worse, bad enough, we're going into that anaerobic metabolism, and we need to try to correct that. So you guys, here's numbers you'll need to write down or highlight. Brain tissue begins to die in 4 to 6 minutes, and we cannot get it back. That is a stat or whatnot you might see again. Brain tissue dies within 4 to 6 minutes. This is the number that they use the quote, like, why is bystander CPR so important? Because of this right here. Even in a good metropolitan, quick, on-duty fire ambulance service, it's really hard to get people on scene within 4 to 6 minutes just to do airway management and CPR. So this number right here is why they want such good community CPR, AEDs out there, stuff like that, to try to get people perfusing, even if it's artificially, within this time frame. Because after 6 minutes, we can't get that brain tissue back. So guys, here's what we're going for. This is a picture I threw in there. At the very end of this, when we're bagging someone, or when we want something to breathe, this at the very end is what we're looking for. Those nice, plump, not overextended alveoli, but they're getting good gas exchange. The vasculature is right up next to it. The carbon dioxide can come off or come into the alveoli. At this point, the oxygen can come off. So this is what we want those things to look like. And then some ways that we can accomplish this is like good bagging, maybe PEEP and CPAP. You know, a little bit of backwards pressure to pop those things open. At the other end, this is what we want. So that thing says food particles, but that's glucose. So cells, particularly your brain, need two things to function. They need glucose and it needs oxygen. And then the byproduct of that coming out the other side is the carbon dioxide molecules. But our cells need two things, oxygen and glucose, to make energy and to work properly. The byproduct of that is carbon dioxide. So to make that work, we have to have proper blood sugar levels. We have to have proper oxygenation and ventilation. And then we have to have a way to get that carbon dioxide back out, to exhale it back out, which is good blood flow and good exhalation out the lungs. Okay, so oxygen reaches body tissues and cells through breathing and circulation. So again, both those systems need to be working. That VQ that we talked about, so ventilation, air going in, the Q is perfusion. That there's blood circulating, that the blood has red blood cells, and that it can do its job at the other end. Okay, during inhalation, oxygen moves from the atmosphere into the lungs. Remember, so intercostal muscles, your chest expands, your diaphragm drops. Atmospheric pressure is going to try to kind of push air in. When all those try to contract in exhalation, it's kind of a passive process. It's just going to do it, and it should blow that back out. Hopefully it's blowing the carbon dioxide out. Remember, so asthma and like COPD patients who are exacerbating, they can typically get air in, it's getting air out that you will not, that they have a hard time with. One thing you guys will see is something called pursed lip breathing. So you guys write this down or whatnot. So a sign that you will see with your patients is something called pursed lip breathing. And they almost kind of pucker up a little bit. They kind of, and you see them, they're physically working, but they're breathing out kind of through narrowed lips because they're trying to almost PEEP themselves. They're providing a little pressure in their mouth by pursing their lips and just trying to keep those alveoli and stuff open. And that's another good thing to note and document is that your patient, you know, walked into a patient who was tachypnic sitting in the tripod position, speaking in 2 to 3 word sentences, and they were breathing through pursed lips. I mean, those are all 4 things that tells you they're having a significant time breathing, particularly getting air back out. So asthma or COPD attack. So again, here's some anatomy again. Why this is really important. Sometimes this stuff can become swollen, inflamed. There can be something in the way. Some people have congenital abnormalities with it. And another thing is you guys are going to be sticking stuff in here. And you need to know where it's going. So when you put like an NPA in, it needs to go back almost to the top of the oral pharynx there, to the back of the nasopharynx, right behind the tongue to open it up. The oral pharynx, if you put in an OPA, is really important that that's sized right, because if it's not, if it's too small and it doesn't go all the way back, you could actually, it'll grab the tongue and push it to the back. So that's why it's important to know the anatomy there, because you guys are going to be sticking adjuncts in there and you need to know it's going in the right spot. So, you know, if you were to have a picture like this that's blank, you should be able to try to label most of these. Okay, the respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. The airway is divided into upper and lower airways. So in class here and out in chat land, you guys, what could happen with the physical structures of breathing that could interrupt ventilation and respiration? What are some things that could happen to our patients? What are some things that could happen with looking back there? What are some things that could happen? So choking, good. Foreign body airway obstruction, so there's something physical there. Whether it's in the esophagus and it's so big, impaling on the trachea, or it's in the trachea itself.
Pharyngeal swelling. So
swelling, good. So there's actually some medicine. There's one called lisinopril that people take for like high blood pressure and whatnot. Sometimes even that can cause laryngeal edema, and it's sometimes people, if they switch manufacturers or they switch a little something in that drug, it can cause laryngeal edema. Trauma can cause that too, where there's swelling there.
What would you say, anaphylaxis, the same thing?
Well, yes and no. Anaphylaxis does 2 things. It causes swelling, inflammation, but it's a type of shock, and it actually dilates out your vessels. So now your perfusion part of that isn't working either. Okay, so on chat here, we have a swollen tongue. Good. Maybe some allergic reaction. So in Joseph, they said trauma, but what are some specific traumas that could happen here? So teeth, okay, facial trauma, obstruction. You know, someone's knocked out, they're hit with something, now they're laying back, now they have teeth and blood back in their airway, okay? What other kind of specific traumas could affect the structures of breathing? Anybody here? What else? So yeah, so someone's riding their bike and they crush their larynx, hit their throat, they're riding their bicycle, like there's a cable across there. Or someone gets boot stomped across their neck. So that could collapse, it could swell. So a broken, so some other answers we have here, a broken nose, a throat punch. Someone's kind of angry mentioning a throat punch. Okay, a punctured lung. So with a punctured lung is all, just think about broken ribs. Remember the muscles, the structure of the ribs, that's helping expand and contract. So here's something you guys need to write down. There's something with fractured ribs called a flail segment. Okay, you guys will see this on a test, I'm sure, at the state level. So a flail segment is 2 or more ribs broken in 2 or more spots. So imagine that there's this kind of an area of rib that are now separated from the rest of the muscles and rib. So as you're breathing, you're not getting good. That little part of it is very painful, and it's not contracting and expanding very well.
Could you say that again? 2 or more ribs?
2 or more ribs broken in 2 or more spots is called a flail segment. So another thing that happens with trauma to the chest is something called a pleural effusion. So just think about a bruise on your lungs, that there's a spot of like blood and fluid collection on your lungs. And then think about that fluid, how it's interacting with the alveoli. It's collapsing it down, it's separating them out from the vasculature. So that's a pleural effusion, and it can just hurt that gas exchange there in the lungs. So there's another thing that you guys need to remember, write down, called a pneumothorax or a hemopneumothorax, which is where there's air or blood between the lungs and the chest wall. So that's where you hear like collapsed lung. That's what's going on. There's actually like a puncture in the lung, which might go back to an impaled object or a broken rib. So the lung is physically punctured and it's air's leaking out. It's not coming out your mouth, but it's going into your chest cavity. And as that pressure builds, it's called a tension, and it's actually squeezing that lung down. So that's pneumo. So pneumo, for your medical terminology, is air. Hemo is blood. So you could have just a hemothorax, which is just blood causing that. You could have a pneumothorax, or you could have a combination, a hemopneumothorax, which is causing a collapsed lung from air and blood being in the chest cavity. Good, so knowing these structures, it helps us have an understanding of what could go wrong with them, so how we could fix it. Okay, so the diaphragm, remember the diaphragm moves down when we're trying to inhale. Chest wall muscles are going to come out and expand out, try to expand our chest wall. Accessory muscles, so we might be using our stomach muscles, our muscles in our shoulders and our back. And then nerves from the brain and spinal cord to these muscles. So we didn't talk about that, but maybe something is not simple, but as just a nerve injury, an impaled object in the back or a car wreck, something where you have maybe a C, cervical fracture. Now that nerve intervention down to your diaphragm is cut off, and then that will make you not breathe or breathe well either. So just nerve damage. Okay, the upper airway consists of the nose, mouth, jaw, oral cavity, pharynx, larynx. We just saw a picture. We've gone over this. Again, I'll just let you guys know. You should be able to label that picture if it was blank and kind of know where these things are at. So we're going to move on. Okay, the upper airway's function is to warm, filter, and humidify air. You guys will want to highlight that, write that down, what that function is. So the upper airway's job is to warm, filter, and humidify air. And then you see that the pharynx is just the components kind of in the back of your mouth, from your nose, your mouth, down to where your trachea is. Kind of all the back of that is known as the pharynx. And if you're talking about the nasal, the oral, meaning your mouth, or laryngopharynx, right, kind of by your vocal cords, that's your larynx. But you'll need to remember what the upper airway's function is: warm, filter, and humidify. So here's kind of a view if it was sliced right in half. That's your pharynx right there. So your nasopharynx, your nose hairs, all those little turbulence in your nose, is meant to warm the air and clean out all the dust, the mucus, and everything else that we're breathing in all day. So the oral pharynx, remember that kind of two things go in here. We have food and we have air going in, which can cause a problem for some people if it's, some people with dementia, little kids, like they physically have to think about how to have this system work. Everyone here has probably drank something, had, quote unquote, something go down the wrong tube or whatnot. So our patients can have an issue here where they have a foreign body, maybe someone didn't chew a hot dog or steak good enough. And these two systems, they come together. And does anyone know what structure helps protect this in the back of your mouth? What structure is the little flap that covers your trachea when you swallow? The epiglottis. Yeah, everyone's frantically typing, but yeah, it is the epiglottis. And now they stop typing, they're mad. Okay. So here's a view. This is actually something called, you don't need to remember this, but it's called Malin Patty. And there's different views. And it's really interesting. Not everyone has this view. So like in lab or when you guys go out and start practicing assessments, it's really interesting to have someone, they have to be sitting upright, but have them open their mouth and stick out their tongue and see how much of the back of their airway that you can see. Some people, you see a great view like that, if not even the top of the vocal cords. Other people, due to small mouth, big tongue, whatnot, like you can barely see the roof of their mouth. And those people are difficult to try to get airways on, to intubate, things like that. But not everyone has a view like that. There's actually 4 different grades. And so just everyone's anatomy is different there, which it could affect like how you bag or how you get an OPA in. But that's called a Malin Patty view, or a test right there. So here's your larynx, so like your Adam's apple, your speech, your vocal cords, everything going down into your trachea. And this is the end of your upper airway. And here we're transitioning into your lower airway. And again, you guys have talked about the main things that could happen here. So swelling due to trauma, anaphylaxis, a foreign body, some type of congenital where like the esophagus and trachea meld together, anatomical differences. And then other surgeries too, people that have had glands removed, other surgeries or whatnot in this area, can cause problems for us when we're trying to get their airway. So remember, there's a difference with kids and adults. So kids can have a lot more occlusion here. Remember their trachea, I always kind of compare it to a flexi straw. You don't want to hyperextend or hyperflex their neck because you'll occlude that airway. Like on an adult, you can crank their head back. And sometimes you have to get a good seal and to get good air in. But if you do that with a kid, then you're going to overextend and actually clamp off that trachea. So kids, you just want to put them like what's in the sniffing position, or like put a little towel or something under their shoulder, because when their head drops to the table, that's about where you want them. You don't want them overly extended or flexed, because you'll have a problem right here where this will clamp off. Okay, the lower airway's function is to deliver oxygen to the alveoli. And going down the trachea, we hit the bronchi, and then into the lungs, and it kind of breaks down from there. We have the trachea. So the part where the trachea splits and goes into the 2 lungs is called the carina. This is kind of some anatomy. And then we go down the bronchioles and then down into the alveoli. Okay, conduit for air into the lungs, divides the carina at the 2 main stem bronchi, right and left. Everything's supported by cartilage, and then the bronchi, they're the big tubes that kind of put your air down into the lungs.
Now I have a question.
Yeah.
So the book said something about the 4th intercostal space. Is that where the carina is? 4th intercostal space?
It's pretty close to that. I can't say for sure, but yeah.
It said some other stuff about the sternum, and I was getting confused. So
Oh, okay. Yeah, that's got to be pretty close to where it's at. So one thing that's interesting about the lungs is that this system, like if someone breathes in, it's not 100%, like it's not a perfect system. So like right now, as we sit here, we're standing, gravity is making the blood kind of go towards the bottom of the lungs, and the air is kind of staying towards the top. So imagine someone that is laying down or to their side, like everything's going to shift that way. If someone's laying on one side, the blood's going to kind of want to pull down, and the air is going to rise to the top. So it's not evenly diffused throughout this. Think about dead space. So that's why it's really important when we're bagging, we're trying to get it to where we see a little bit of chest rise, because that's kind of telling us that we're getting air distributed throughout the entire lung field. when we have it inflated and we're seeing a little bit of chest rise. Not a lot of chest rise, and some people we can't, but we want it to where we know that we've got air distributed throughout the whole field. So trachea going down, the smaller bronchioles connect to the alveoli, oxygen transported back to the heart and distributed to the rest of the body. Okay, so with anatomy here Chatland, when blood comes into the lungs from the right ventricle, what does it travel through? And what's the difference here with our vasculature? So lung from the right ventricle into the lungs, what's it coming through, and what's the one difference here in our body? I see people typing, so we're just waiting a second. Then you guys in class be prepared to answer what the other vasculature is, where it's coming back, and what the difference is there. Okay, so oxygenated blood is coming through a vein. Oh, she already answered it. Deoxygenated blood is coming back through an artery. So as it leaves the body, remember, you guys will see this on tests later. This is a pretty popular question, like at the state level. When blood leaves the heart, that's an artery, so arteries away. But the pulmonary artery, when it goes into the lungs, that's deoxygenated blood, and that's the one time that there's a difference. Coming back is a pulmonary vein, and that has oxygenated blood. So that's the one time that vasculature is kind of switched in our body.
So the pulmonary artery goes away from the heart.
It goes away, but it has deoxygenated blood.
Yeah.
Yeah, exactly.
Away from the heart.
Yes, I always think of arteries away. Sorry, I try to remember it. So the names are pulmonary artery, pulmonary vein. The pulmonary vein dumps back into the left atria because then it's going to go to left ventricle. It's oxygenated, then back out to the body. So the vena cava, the inferior and superior is where the deoxygenated blood comes in from the body. And then the aorta is where it's pumped, oxygenated blood is pumped out into the body. Okay, the mediastinum, the space between the lungs, contains the heart, great vessels, the esophagus, trachea, the bronchi, and many nerves. Again, you guys should be able to know what's in the center of the chest. The respiratory and cardiovascular systems work together. We've talked about this, quite a bit, and we're going to hit on it a lot. One system needs to be, both systems need to be working. If one system's not, it's harder for the other one to do what it needs to do. So we need to have oxygen air going in and out of the lungs with ventilation, and we need to have perfusion. And we see a lot of patients where they have a problem with one, if not both of these systems, especially in trauma. But think about it, as an EMT level, if you simply stop bleeding and can bag them, you might have fixed both these major problems with some simple stuff. Put a tourniquet on, start bagging them, and now you're fixing this issue. Okay, so again, ventilation's there in and out of the lungs. Oxygen is a process of the gas exchange and the cellular respiration at the other end. Okay, so Chatland, here's a real simple one. How many ATP are we shooting for with aerobic metabolism? How many adenosine triphosphates, how many units of energy are we getting at the cellular level if all this is working right? And then the other question will be, how many do we get if we're in anaerobic and this is not working right? Okay, so when this isn't working right, okay, so we don't get oxygen, okay, we're getting about 2 to 4 ATP. Okay. If it's working great and we're getting all the energy, there's glucose, all of that, I think we're getting 34 to 36. 34 to 36 ATP. So again, we want to keep this system working to keep that energy level, that energy production up, and that there's no byproduct. So if we go into anaerobic metabolism, which means we do not have good cellular respiration, what is the one bad byproduct? It's a type of acid. Does anyone remember what type of acid is produced? So we want pyruvic acid, but when we don't get the gas exchange and whatnot, it switches to another. And it's the one lab that we measure with trauma. It's the gray top. Lactic acid. I was hoping the lab tech would get it, but she's not typing fast enough. So lactic acid is what will build up and cause our problems. Very good. So ventilation, we want air moving in and out of the lungs. We do that, naturally. Our patients do it, hopefully on their own, which is inhalation. Okay, the lungs require the movement of the chest and supporting structures to expand. So partial pressure is the amount of gas in the air or dissolved in a fluid, so blood. This is kind of a really complicated rule. There's lots of rules on gas diffusion. Like if you're a pilot or if you're a scuba diver, they go in like Boyle's law, Henry's law, all kinds of stuff like that. But so sometimes what this is talking about is imagine like you're at sea level, and we see a lot of patients in this county that do this. You live at sea level, okay? Like there cannot be any more, the oxygen is as compact down as it can be in the air at sea level at 20.9 or 21%. What happens is now you come over to Wallowa County and you want to get on the tram and you want to go up to Mount Howard, and you go up to the top of Mount Howard and you're kind of fat, you're out of shape, or you have asthma. Now that air, like it's still 20.9, but the air that it's in is bigger. So when people are breathing in, they don't get the full oxygen. They don't get all the molecules that they should get. And that's why when you go up like Everest, like the air is so quote unquote thin that you have to wear supplemental oxygen because you cannot breathe in enough oxygen molecules. But that's what it's talking about there is how much oxygen is kind of saturated into something. Is it in the air or in our blood?
So what you say is you go up in altitude, your pressure levels between your lungs and the atmosphere kind of equilibrate.
Yeah, you can't breathe as well yet. Or what you're getting in is not saturated with good oxygen. Yeah. And then to breathe in too, so the diaphragm goes down, your intercostal muscles go out. Now you don't have 14.7 psi trying to push stuff in. You might only have 10 if you're up really high. So now you're physically now you're negative pressure because you're actually physically having to suck air in, because now you don't have the atmospheric pressure is going down as you climb.
The oxygen level never changes.
The oxygen percent never changes, but the space that it's in changes. So it's kind of the same thing. You don't get all the oxygen, down your alveoli to use. It's pretty complicated. Like I said, Roland, don't get wrapped up in it. Just keep in mind that sometimes when people are breathing in or saturated in their blood, they might not have all the oxygen that they need. And how can we fix that is maybe with supplemental oxygen, which we'll go into later. So like the bottom thing saying there, so air, let's start with down at cellular respiration. CO2 is offloaded. Okay, so in the cell and in the blood, I don't know what the number is, it's 40, okay, millimeters of mercury. As that little molecule of blood goes, the next one that comes along is maybe at only 10 or 0. So, and then in the cell, it might be 60. So it's going to higher concentration to lower to try to equalize as that's that's going across. As that blood goes across that cell, it's dumping the CO2 onto it, and then off it goes like a little train out to the lungs to be expelled out. And there's lots of stuff that can mess up that system. You know, maybe something's oversaturated or not saturated enough. So here, diaphragm relaxes to breathe in, and then it contracts up to help breathe out. It's kind of an over simplification of a picture there. So tidal volume is the amount of air that you get into your lungs in one breath. And there's some formulas for that. But for an adult, it's around 400 to 500 milliliters for an adult is how much we want to breathe in. So what could affect tidal volume? So what could affect how much air you get in one breath?
Altitude, pressure changes.
Yep. Okay, altitude, pressure changes. What else? In Chatland, what could affect what could cause you to not get enough or too much air in one breath? What's some things that could happen? COPD, good. So a lot of times the COPD is emphysema, like the alveoli are literally destroyed. Their lungs become kind of brittle and where they're not as elastic. So they just don't get they don't get good quality air in every time. So instead of get 400 mils 20 times, they get 200 mils 26 times because they're trying to breathe a little faster. So good. So in the pneumonia, Jennifer's pointing out pneumonia. One thing that can cause pneumonia is, so you're an elderly person and you fall and break your ribs. Well, it hurts to breathe. So that kind of whacks you double because now you have broken ribs. So now you don't breathe very deep because it hurts. And in that spot, so there's one way you don't get good tidal volume. And now you have a big pussy ball infection down there that air might not get down to it either because there's no gas exchange. It's filled with mucus and pus. So your tidal volume, you lost all that space there. So pneumonia can, if it's from a trauma, can actually hurt twice. So then there's one answer, CO poisoning, so CO poisoning is you probably get your tidal volume, but it's not working at the other end because the carbon monoxide is keeping the oxygen from binding with the red blood cells. So you're probably getting your full breath in. But you're having a problem at the other end. You're ventilating, but you are not oxygenating. You're not having good respiration. And then maybe an obstruction, which might be foreign, or it might be inflammation, something like that. Good, very good. And then again, sometimes we have to correct this, a lot of times with the BVM, where we have to try to get that volume in there. Okay, exhalation typically doesn't require physical thought. It doesn't force you like to use your voluntary muscles or whatnot to try to blow air out. What the exception is asthma and like COPD. Those people actually physically have to try to breathe in and out. The reason you look at someone, you can walk into a room and see, and you know someone has emphysema, is because they're skinny as a rail. So emphysema, it's called, you guys probably want to write this down, barrel chested. Okay, you go and look, and you see that they're sitting there, and you can see every rib. Like they're hyperinflated, they get air in, but they can't get air out, and pretty soon their body just adjusts to that. And they are so skinny and they look malnourished because all of their energy goes into breathing. So where it's passive for us, they physically have to work air in, air out.
There's a good picture on 401.
401, there's a picture of it. So in your book, Patrick points out, and Loring's calling the pink puffers, where, is it blue bloaters, Loring, that are chronic? There's emphysema. Like now I drew a blank on the other
I
one.
can't remember which one.
Blue bloaters. It's is it chronic bronchitis?
Could be. I think pink puffers is emphysema.
Loading points out pink puffers are emphysema. Yeah.
Okay. So you guys, as EMTs, ever talk about the air trapping at all? Air trapping here and why?
A little, yeah, a little bit, and we'll probably go into the air trapping more with the respiratory problems when we get into that specific.
Gotcha.
So yeah, so compared to a pink puffer emphysema barrel chest, we have I think it's chronic bronchitis, but typically those people are overweight and they actually have like an overproduction of mucus. They're inflaming that probably from smoking. They're inflaming that ciliary, all that protective measures, and they just have constant mucus coming up from damage, probably from smoking. And so those are kind of the two COPD people that you'll see, and then another one they kind of sometimes tag on asthma with that. But when you think of COPD, it's emphysema and chronic bronchitis. Okay, so you guys should know this. Air comes in and out of the trachea. So regulation of ventilation involves a complex series of receptors and feedback loops. So like we talked about in the medulla, in the pons, some in the aorta, it's measuring in a typical, normal, healthy human, it's measuring your carbon dioxide levels. There's some thoughts that if you destroy those, because you're a COPD and you have those levels high all the time, you kind of burn them out and your body goes to what's called a hypoxic drive, where it measures the amount of oxygen, but your body is actually measuring the amount of carbon dioxide, which is stimulating you to breathe, to try to blow that out. So pH changes in your study guide. So remember, if you're what's called hypercapnic, your end tidal, your carbon dioxide is going up. So what's the normal range for carbon dioxide? By the textbook. 35 to 45. So if you're above that, like if you're at 60, then you're retaining that for whatever reason. You can't blow it off, whether from lung damage or whatever it is. But as your carbon dioxide builds up, think of carbon dioxide loosely as an acid. So as that builds up, you're becoming more acidotic. So what will your pH scale do? On the pH scale, if it goes down or up, which one's acidotic? Yeah, it's down. Do we have a power surge on? Hey, you guys, something happened here at the hospital. Can you guys still hear me? And
I did hear a fan turn off out there or something like that. Yeah.
okay, hold on a second. We had a problem here with the display.
Are we good for a quick head call?
What's that guy? Sorry guys, we lost all of our display stuff here in the classroom and my computer went blank. So give me 1 second to try to get it back up. You guys, let's take I gotta fix this, figure it out. Let's take a 15-minute break, come back at 1900 hours. So sorry about this. So it's 1900, we're moving on. It's like some of you guys are saying you're back, thank you. So oxygenation, remember, ventilation is getting air in and out of the lungs. Oxygenation is at the other end, where we're trying to get good oxygen diffusion to the cells, get carbon dioxide off the cells.
I thought that's respiration.
Well, it's kind of saying at that end, we're trying to oxygenate the. And like some of you guys mentioned too, almost with the partial pressures, we can have ventilation without oxygenation because there's no air, there's no oxygen in what we're trying to breathe. Maybe a house fire, or like it says there, confined space, mines. Oh, maybe, sorry, okay. Then respiration, like we said, like Patrick, like you said, is down to cells. So remember, sorry, respiration's down to cellular level. We're trying to get oxygen to the lungs by ventilation. And remember, whenever it says nutrients or food or something like that, it's talking about glucose. So there's external respiration, where the air is going into the lungs and into the alveoli, doing gas exchange there. And then it's going down doing a cellular respiration down at the capillary beds, where the O2 and carbon dioxide are transferring down at the cells. Which is shown there, they're calling it internal respiration. So by this curriculum, they're showing pulmonary respiration and then internal respiration, or cellular respiration. Okay, so again, try to remember these numbers more. The most important one there is 4 to 6 minutes where you're having brain damage, probably irreversible. But definitely after 10 minutes, it's irreversible. So again, this is why airway management, good CPR, and getting people artificial ventilation and respiration, because we can't get this stuff back. So like we've talked about, chemoreceptors, again, located in the medulla and the pons on your aorta. It's monitoring oxygen levels, carbon dioxide levels, hydrogen ions, so that's your acid level. There with the pH of the cerebral spinal fluid. And it's all providing feedback. So when these get out of whack, it's trying to stimulate your body either to breathe less, breathe more, breathe faster, breathe deeper, based on what these receptors are measuring with what it's measuring here. And again, the big one it's measuring is carbon dioxide. So a ventilation perfusion mismatch. So out in chat land, about how much blood are we circulating versus how much air are we breathing in and out? Do you guys remember what those numbers are? How much blood are we circulating and how much air, how much ventilation is going on in liters? Yep, so 5 liters of blood and then about how much air going in and out. So it's about 4 liters. So the idea, so it's 0.8, okay? But think about it simply, what this is talking about is blood going round and round, air going in and out. And a mismatch is when something screws one of those systems up, or both of them. So are you bleeding out? Are you not ventilating well? Are you ventilating too much or not enough? So just a ventilation perfusion mismatch is when something screws up that 5 to 4 ratio. 5 blood around, 4 air going in and out. So, and then down at the lower levels, what could be causing oxygen to not go across the alveoli? What could cause carbon dioxide not to come back? What could be causing oxygen not to get to the cells, carbon dioxide? And like some people mentioned, maybe CO poisoning. Is there not enough blood circulating? Is your heart in cardiogenic shock and it's not pumping the blood very well? The big one you guys will see when you're doing the end tidal is, let's say someone's hyperventilating, they're in some type of emotional shock or whatnot, they're breathing really, really fast, you're going to see end tidal really low. If it's really high, they're not breathing it off, but everything's still working down to cellular level, so they're offloading carbon dioxide, but they can't offload it, and what is offloaded is higher than normal. So this is where you're above the 35 to 45, you're going to see 50, 55, 60. When you start getting above 60, you're starting to look at imminent respiratory failure and distress. That's too high, especially when you get above 60. Remember that these are numbers, and some people live at 50 because they're COPDers, and they're constantly having a hard time getting that gas exchange. So some of these you guys have already mentioned. Infections, okay, like a pneumonia, allergic reaction. So we have constriction. We have, with allergic reactions, inflammations up in the bronchioles. So there's, constriction, but then at the same time with allergic reaction, and especially anaphylaxis, you get the double whammy that your vessels are now dilated. So now not only are you getting poor air in and out, but now you have the VQ mismatch that the blood circulating, the 5 liters is now trying to circulate in a 7-liter system because it's all dilated out and went on you. I mean, you guys have already got these trauma, fractured ribs, a penetrating injury, or is it something physically blocking the trachea or something in the esophagus that's pressing in on the trachea? Okay, factors affecting respiration, so that offloading, we're down deeper into the lungs. So the infections, the pneumonia, the pulmonary edema, the COPD, emphysema. So what's happening there, again, is there's fluid, there's pus, there's whatever, that is squishing those alveoli down. There's stuff around it that's pressing them down, and then it's separating out the veins and the arteries that are right next to the alveoli. It's literally moving those away because they're squished down, so then we don't get that good gas exchange. And then again, how you guys fix that is good BVM with PEEP or CPAP. A CPAP machine, or like I'll show you later, a flow safe. We want PEEP to pop those alveoli back open. Did anyone look at any of the videos I sent on like the rat lungs or the PEEP videos? Really good, it shows that those lungs expanding with a little bit of PEEP. If you guys haven't watched those videos, we sent out some good videos on what PEEP is and how it works. Okay, circulatory compromise. So what else is going to mess up this VQ? What's going to cause us a VQ mismatch? So we don't have enough blood going around for whatever reason. Maybe it's like this slide showing is due to trauma. So you guys, so write this down and note it. A pulmonary, a pneumothorax, excuse me, is not like necessarily an A or B problem. It's a C problem. It's a circulatory problem because think of that blood. One, if it's a hemothorax, the blood's not in the vasculature. It's not where it's supposed to be. But that lung, that pressure, that air, that blood is pressing down on the heart. It's pressing down on the great vessels, the aorta, and all that. So that a pneumothorax is actually kind of a C problem because it's affecting your ability for your heart to pump and the pressure in your chest, and especially like around your great vessels, which can be hard to wrap your head around. You're like, well, it's an airway or breathing problem because they have a compromise, but it's really affecting some of your circulatory problems more than the other. And we've already mentioned, so a pulmonary embolism, if we haven't mentioned that yet, is a clot that's traveled around, from a vein thrombosis or a surgery or whatnot. It's made it through your heart and it gets stuck in the lungs. So now, however big that is, whatever vasculature is beyond that clot is not getting blood. It's getting air. There's ventilation going by it, but the blood in that part of the lung is not getting able to do gas exchange. Okay, blood loss. Again, this is something you guys can fix, hopefully, if it's not an internal bleeding. Blood belongs in the body, not out on the sidewalk. Airway, breathing, and circulation. You guys need to stop bleeding. Remember, with a patient with low blood pressure or shock for the EMT, you guys need to write this down. It's hypovolemic shock until proven otherwise. That's the most common type of shock. So you guys need to look for bleeding or suspect that it's bleeding if it's shock, unless you guys can find something else. Vasodilatory shock, so that would be like you're neurogenic, so you have a trauma to your back, and your nerves can't tell your body now what to do in a trauma. So your veins just kind of, and your arteries kind of go bleh, and they dilate. Or it would be like anaphylaxis, where again, it's the same thing. It turns into a 7-liter system when it's only circulating 5 liters of blood. They all dilate out too. Okay, so this is stuff you guys will be tested on. So what are signs? We're going to go through adequate, and then what are signs that your patient is not breathing well? And you guys will see test questions on this from your state exam, I'm sure. So these can be pertinent negatives. You're looking at someone and go, oh, there's bilateral chest movement, which means there's equal movement on both sides. Regular chest rise and fall, a good tidal volume. So if someone's hyperventilating, they're breathing 40, 60, 80 times a minute, they're not getting good tidal volume. That's the amount in one breath. So you got to get them to slow down and take a deeper breath, because they are not adequately perfusing or getting off air down to their alveoli. They're not filling up their chest if they're hyperventilating that bad. So they have poor tidal volume. So on an adult, 12 to 20, regular breathing, bilateral clear, equal lung sounds, regular equal chest rise and fall, and then good tidal volume. One of the guys mentions the swine lung video. I think back there when we butchered our pigs, I kept a trachea and lungs from a pig, so hopefully we can defrost those, and you guys can. We'll do that here in class. We'll look at that PEEP, and we'll do that experiment if I can salvage that trachea and lung from my pig. Okay, so here's abnormal breathing. So you're looking at someone, you're gonna need to recognize and document this. So fewer than 12 breaths per minute, more than 20. It's an irregular rhythm, which an irregular rhythm could be emotional, or it could be something very serious like a brain involvement of the brain, trauma or aneurysm or something like that. And then you could have very irregular pauses, breathing fast and shallow, long and deep. Like different types of headers, you go different types of respiratory patterns. So here's some more things that are indicative of abnormal breathing. So unequal or inadequate chest expansion, increased effort, a shallow breathing, shallow depth, skin that is pale, cyanotic, cool, and moist, meaning they're not perfusing. And then skin is pulling in around the ribs, the clavicles. Again, that's called retraction. It's very obvious in kids and people with emphysema. If you want to just put retractions, that's what it's talking about, is where that skin's sucking in because they're breathing so hard to try to breathe. So here's an example of that irregular breathing pattern. This is called Cheyne-Stokes breathing. So you can see that there's kind of a very irregular pattern. There's pauses, it gets deep and shallow. And again, Cheyne-Stokes is related to a stroke or head injury. Every once in a while, you'll see that on a test too, where it'll say, hey, you have a patient doing this, what type of breathing pattern is that? And it'll ask you it in that format. There's something called agonal respirations, which are not productive respirations. But to me, what these are is, imagine that your body's been breathing your entire life and your heart stops, your brain stops working, but your body just has a couple more, efforts in it, and it's not productive. It's just kind of these big, like over dramatic kind of gasps, and a lot of times those get mistaken by bystanders as breathing. You'll walk up to a cardiac arrest like they were just breathing, but it was most likely these agonal respirations that they were seeing because they just didn't know what they were. And they can be very dramatic too. Okay, ataxic respirations kind of goes along with the Cheyne-Stokes, just irregular. There's just no pattern to it. And again, a lot of times irregular breathing patterns like this revolve around head injuries. Okay, Kussmaul's respirations, deep, rapid respirations, common in patients with a metabolic acidosis. If you guys walk in and you see someone breathing very fast, very deep, you need to check a blood sugar. This is a common respiratory pattern with people who are hyperglycemic or they go into what's called DKA, diabetic ketoacidosis. And a lot of times people report that when you're in this diabetic ketoacidosis, when they breathe out, it actually smells fruity. What's happening here, it kind of goes back to what we talked about. Their body can't use the sugar. Their blood sugar's building up, but their body actually starts breaking down other stuff for energy. So they get a lot less ATP, they get a lot less energy. But that breakdown of like fat causes them to breathe out like a fruity odor. And we're going to hit this again with diabetic endocrine emergencies. But if you walk in and you smell like a fruity odor and you see these big, deep respirations, you need to check a blood sugar. These are really common in diabetic ketoacidosis or DKA. So again, treat your patient. So even though you said like, oh, they seem like they're breathing okay, but they're not. They're pale, their sats suck, they're whatnot. You need to be looking beyond just the ventilation, just the, well, I see chest rise and the pattern that you see, because maybe like someone mentioned, maybe it's CO poisoning. Maybe they're breathing for all get out, but they're not getting any oxygen down to their cells. And when stuff like that doesn't make sense, you need to start looking around and start wondering if you're in a safe environment, if there's fumes or something like that. Because you need to go, wow, something's not adding up here. Okay, pulse oximetry. Again, it's a great thing, but as we've demonstrated, it can be kind of delayed, or there's things that can make it unreliable. So it's one of those things where, if it reads 99, everything's good, we kind of say it's working. But then at times when it's not working, my God, the stupid thing's not working. It's one of those things that we kind of cast off sometimes. But we should put this on every single patient because it's just a good number to have where they're standing at. And remember, if we put them on supplemental oxygen, it can take several minutes for that number to come up. Okay, emergency medical care begins with assuring an open airway. We're going to keep coming back to this. Airway, breathing, and circulation. If you don't manage this, anything you do beyond that, B, C's, D's, Z's, doesn't matter if we don't start here and manage this. Even, like I said, if you're in your state test and you're down and you say, hey, airway looks good, say something like, but I'm going to continue to monitor it. I'm going to always be looking at the airway, breathing, circulation, even when you're down at dealing with some fractured ankle. Like, make a point to look up and kind of scan them over. They really want to ensure that you're paying attention to this, the whole patient contact. So if someone is unconscious, the supine position is the most effective. If someone is conscious, most people don't like being laid down flat. Even in an ICU where people are intubated and whatnot, they like them in an angle because it helps with like that gas mixing all that in the lungs. Laying down should really be reserved for someone that you think has like a bad spinal fracture. Most other people, 99% of the people, we try to get sitting upright. And if you can't breathe, you will not. No one will lay down flat. So, but if they're unconscious and you have to manage their airway, them laying flat on their back is the best way to do it. If they're awake, that's kind of a bad position to keep people in for transport. Unconscious people should be moved as a unit. And remember, like we showed that one picture where the guy was on the backboard, his head was secured, nothing else. Like if he were to start vomiting and they turn him, like his body will flip off the board, but his head stay put. That's a bad thing for that. So we need to try to make sure we move them as a unit. When you're moving, like in your trauma assessments, okay, whoever's on the head, like write this down or note it, whoever's on the head, guys, is in charge of movements. So you want to say, okay, whoever's on the head, you're in charge. Okay, we're rolling to the right in 3, 2, 1. And it's always the person on the head that's controlling these movements. Okay, the most common airway obstruction in your patient is going to be their tongue. And we're going to talk about 2 ways in what situations to move that tongue out of the way. The most common obstruction is their tongue. Other causes, dentures, or even their real teeth. You know, someone gets bashed in the face, they have teeth sitting back there. Okay, blood. A seizure patient that's bit their tongue really bad could have blood leaking back there, or a trauma. Vomit, mucus, food, and other foreign objects. Rocks, Legos, hot dog, whatever. Little kids like to stick stuff in their mouth.
How about tonsils?
Swollen tonsils and adenoids, absolutely. Or some type of other hematoma, hemorrhage, or something else going on that swells. We've flown out several people from here who are developing, like they just had neck surgery and they nicked something in there and they come home and 2 days later they start noticing swelling from their surgery sites. So, okay, so there's two maneuvers here and you guys will need to demonstrate and document when to use them. So a head tilt chin lift is for people who have not had trauma. These are atraumatic people. You can use the head tilt chin lift. And it's demonstrated there in that picture. So put your head on one hand on their forehead, one under their chin, not super deep where you're pressing up under their hyoid in their skin, but the tip of their chin, and you just tilt them back to try to open the airway. And remember, head tilt chin lift is for people who you do not suspect have had a traumatic injury. Okay, we just talked about that. Okay, if you think they've had a trauma, you will use the jaw thrust maneuver. In your state test, if you're in the trauma section and you do a head tilt chin lift, you'll fail because you compromise their cervical spine. If they have a trauma, you need to demonstrate or say that you would use a jaw thrust maneuver to open their airway, which can be pretty difficult because what you have to do is you're kneeling there, the angles of their jaw, you're taking their jaw and you're pushing it forward. So you're taking it and you're just moving that lower jaw out, which if they're awake if you guys do it to yourself, it's very painful. But you're going to take it and just lift their jaw up. So this is assuming you go to an unconscious patient or whatnot. Sometimes just opening their airway can get people to breathe again. Imagine this little lady or whatnot that her head, she's in her chair, she's had a medical emergency, a stroke or whatnot, now her head's leaning down or she's slumped over. Sometimes just getting them back and getting that head tilted back will get them to start breathing again. Okay, so here, I really recommend you guys not stick your fingers in someone's mouth because if they're seizing or they bite down or whatnot, you could lose fingers or at least have you know, some traumatic injury to your fingers. But what this is it's, well, you just read it, but what you're doing is you're crossing your fingers, sticking it in their mouth, or and then you're just uncrossing your fingers to try to open their mouth up. So I would try to recommend like a bite stick or something like that, but it is a technique where you can take your thumb and your index finger, put it in there, and you're just untwisting it to try to open their mouth. Okay, so here's a jaw thrust where they're taking their index fingers and just shooting that jaw forward. And one thing with this picture you'll see, so this is kind of the 2 thumbs down technique. So when we talk about BVM, you can do this with a 2-person technique, and you can hold that BVM mask to their face while you're doing this. So you do a jaw thrust, and you're actually holding the mask of the BVM down to their face at the same time. Okay, so suction, guys, suctioning is very important. If someone starts vomiting, if they have blood, whatnot, the first thing you need to do is open their airway, and then you need to be reaching for some type of suction device to try to get in their mouth to get that vomitous and stuff out. If people get vomitous and stuff into their lungs, they're probably going to get an aspiration pneumonia, and now their simple suction them out, get into surgery, whatnot, now just turned into a 2-week ICU stay because now they're on antibiotics and everything else. So we really need to be aggressive at airway management with suctioning. If you guys go to people that they're even nauseous because you guys can't give some of the good nausea medicine, there's nothing wrong with taking that Yankauer tip that's kind of demonstrated in the center and off to in that red portable one there, and just stick it underneath the pillow. Turn it on, stick it up underneath the pillow, so if you need it, you pull it out and you stick it right in their mouth. We do it all the time in the ER with cardioversions and people who are sick or whatnot, is we always have suction right there. The other one off to the far side is a portable one, and that one is kind of a one-way vacuum. As you keep pumping the handle, it just kind of creates a vacuum and sucks stuff in. It's really good for like your airway bag. Okay, the portable or fixed unit in Oregon, ambulances have to have one of each. You have to have a portable unit, and you have to have one that's built into your ambulance. There's a couple different things. It has to have good wide tubing. You know, you start having someone that's had soup or stomach contents, whatnot, it can clog up a smaller tube. And even the ones we have can get clogged up. But you want to be able to have at least fluid, blood, small particles be able to travel down it. Okay, we're going to have plastic rigid suction tips. Sometimes they're called Yankauer tips. And then also we can have ones that are a little more pliable that can go into like stomas and NPAs and whatnot. You guys will probably just be using the rigid Yankauer or rigid tips for suctioning. Okay, to turn on, you guys, a lot of stuff can go wrong with suctioning. We always need to be checking our suction gear like every single day because it's basically a vacuum, but it has a lot of hoses and like a plastic container. So if you think about it, from the suction unit, there's a big tube that's going to the collection can. So if you look in the middle there, look at that collection can. So we have one coming from the supply that comes into this container, and then one going out to the patient. Anything that's loose in that, you're not going to get your vacuum. You're not going to get your suction. So if you have someone that threw the clipboard up there the last call and cracked that canister, you're not going to get a suction. So you really need to be looking at these canisters for fractures and that it's not compromised. If the lid pops off, if the hose is not connected right, any disconnection in this closed system will cause you not to have good suction. So every day in your equipment and your rigs, you need to be going to make sure that everything's tight, and then especially that your canister didn't get cracked, because that's one really hard to see and you'll never be able to fix it without a new canister. Okay, you guys write this down. You will be tested on this. If you do this or don't do this in your state test, they'll fail you. Do not suction for more than 15 seconds at a time. And then I added that picture. That's an example of a Yankauer rigid tip. So most of the time how these work, it doesn't really show it there. So it's connected to your suction unit. You see where the little oval thumb deals are? A lot of time there'll be a hole there that breaks your suction. So what you need to do is put it in their mouth and then you occlude that hole, and then now your suction goes all the way out to the end. And then you suction kind of on the way out, you suction for your 15 seconds. So you need to make sure what type you have, because depending on what brand, most of them have a hole there that you can break and apply suction by covering a hole. And it doesn't really show it there, but there's probably one on the other side in one of those little oval thumbprints. But again, guys, if do not suction for more than 15 seconds, and you want to say that. So in your scenario, if they say, hey, your patient's vomiting, you're going to grab that suction, you're going to say, I'm suctioning, I am not suctioning for more than 15 seconds. And you want to verbalize that to your proctor. Okay, so we run into this a lot. You guys, sometimes people don't chew their food or all kinds of stuff comes out. If that suction catheter gets clogged up, and they will, you just got to get them turned and like get your finger in there with a gloved hand, hopefully, and just start scooping the big stuff out, and maybe with a suction at the same time. But if that gets clogged up, it's not going to suction anymore, and you just have to get in there and scoop it out. We do not want stuff going back down into the lungs. So in like a cardiac arrest, especially if someone has like CHF, they can have this, man, sometimes just the body goes black and stuff from the stomach and lungs fluid will just kind of creep back up. Sometimes because you're bagging or they're trying to breathe, it's kind of frothy. It's hard to see and ventilate. You just got to suction that out, and then you can ventilate, and you just got to keep repeating that process. Sometimes stomach stuff and whatnot just kind of creeps up. So when you're bagging, or you have you guys are gonna learn how to put in a good airway, like an iGel or a King. If you see stuff coming out of that, you'll just need to you need to keep suctioning that, because you don't want to blow that back down into their lungs.
As you get, when you're bagging somebody, don't you need to get a certain amount of air into the stomach after time?
With poor positioning, yeah, you could have gastric inflation, gastric distension. Hopefully, good positioning and good bagging techniques will minimize that. But yeah, and I think we talk about that too, is we really want to try to prevent what's called gastric inflation. And there's two ways that we can do that, because if you put air into the belly, you're going to see what they had for lunch. Okay, basic airway adjuncts. Oropharyngeal airway, so oral meaning the mouth. What it does is it keeps the tongue from blocking the upper airway. It keeps that tongue from falling in the back, and it kind of just looks like almost like a J-shaped plastic device. And there's a couple different designs of it. And this is one of the things they should have pictures, but they don't. So it does not work in people who are conscious or have a gag reflex, that it hits that gag reflex and you're going to cause them to puke. So OPA is only for unconscious patients. You guys probably want to highlight that or write it down. OPA is only for patients without a gag reflex. Does your book have pictures of these? Okay.
I have a question.
Yeah.
So you were talking earlier about, like, when you're suctioning, you're going to tell the doctor you're suctioning for 15 seconds.
Yeah.
With this one here, if they have you put in an OPA, say I'm going to put in an OPA, a patient wakes up, becomes conscious, I'm going to take it out.
Yes.
Do you want to say that?
Yes. Yep. And they'll give you scenarios like that where you put an OPA in, your patient's now conscious, you want to pull it out, and maybe even try to put in an NPA that conscious patients can tolerate. But if your patient wakes up in your scenario or in real life and they start gagging, you want to immediately pull that OPA out. That's a perfect point. Okay, nasopharyngeal, so these go in the nose. Couple hints for these. They can be uncomfortable. With these, you want to lube them up. The OPAs, you don't need to lube them up, but with NPAs, you want to use lube. And there's ways you want to do it. In your skill station, you want to say, quote unquote, I'm putting the bevel towards the septum, because they have a bevel on them. So you want to say, I'm trying to put that towards the septum. Sometimes it doesn't work if someone's had a broken nose or a small passage, you need to move it over. But when you're putting these in, you might just need to twist it a little bit and get it to go back. They have a little bit of a curve to them. So going back to the OPA, you guys write this down. These are measured from your corner of your mouth, okay, back to like your jawline, back at your earlobe. So it's here, and they're measured back around because that's about where they sit. Okay, corner of the mouth, back around to your jawline. NPAs are measured from the tip of your nose over to your earlobe. So again, that's about the right size. If it's too long, you'll make it go down too deep and you'll activate a gag reflex. If it's too short, the tongue could still fall in front of it. So you want it to land right about there. And you'll have to demonstrate that you measure these in your state tests. OPA or NPA, excuse me, are great for seizure patients. People who maybe aren't controlling their airway 100% yet. NPAs can be tolerated by people with a gag reflex. So they're great for seizure patients. Okay, so indications: semi-conscious, unconscious, in patients who are not tolerating oropharyngeal airway. An absolute contraindication, guys, and please write this down or mark it, is you do not put an NPA in someone that has a face fracture, particularly with blood from their nose. Because they might have a fracture, so like their cribriform plate or something, where that instead of curving around, the nasopharynx dropping down, it just keeps going straight. It's probably pretty rare. It's probably only happened twice, but someone noticed it. So this is a test question I'd like to ask you: is what's the contraindication? Or you'll have a patient in your state test with a face fracture and bloody nose, and if you put an NPA in them, you fail. So you don't want to put stuff that's going to go up into their brain. And again, facial trauma with a bloody nose, that you definitely do not want to put an NPA in.
Would that be a contraindication for EMT session too? Or would we get into that?
Probably not get into that. Okay, so here's the recovery position. So someone's vomiting. And this way, at least if they puke, hopefully stuff comes out. My rule is always try to have these people point towards your patient or your partner. Have them puke on your partner. Honestly, I say that, but typically whenever someone starts puking, I always roll them towards me. I just grab them by the shoulder and the hip, and I just yank them towards me because I want to be able to see that mouth and that airway and get in there and get that stuff out if I have to. So, but that again is known as the recovery position. Do that. Okay. Supplemental oxygen, you guys, there's a lot of test questions and stuff that come up with supplemental oxygen. We'll try to highlight as we go through this. So always give oxygen to patients who are hypoxic, or they look hypoxic, act hypoxic, regardless of whatever that SpO2 monitor says. Like I said, an SpO2 monitor, if they're carbon monoxide poisoning, it's going to show 100%. But what it's reading is the carbon monoxide on the red blood cell, not the oxygen. So regardless of whatever your SpO2 says, if someone's hypoxic, in respiratory distress, whatnot, you need to pick the appropriate supplemental oxygen for them. Okay, become familiar with how it is stored. Patrick and I were talking earlier. I don't know if you'll see any questions on it, but you need to recognize that oxygen bottles have different like cubic feet of air, oxygen in them, and they have different lettering. So like a smaller one might be an S, where a big one's an M. So recognize that those have different oxygen carrying capacities, and they're different sizes, and they're labeled with letters. E, M, S, D. Liquid oxygen, we don't use that on the ambulance, but the hospital does. hospital has liquid oxygen systems that go through, but we just use the compressed gas. Okay, handle gas cylinder safety. There's, I don't know if it's an old wives' tale or what, but these things have 2,000, 2,200 PSI into them is when they come full. So imagine that drops and that valve at the end gets knocked off. In theory, you could have a little rocket shooting around. So you want to be really careful not to drop them, not to bang on the valves. If you have to, like in Oregon, everything has to be secured. And if you ever have to leave it on the ground for some reason, like lay it down. Don't have it to where it's sitting upright because they easily get knocked over. Okay, on the bottles, so there's a regulator in the bottle that comes up. When you look at the regulator where the regulator and the valve come together, with EMS bottles, there's two little pins that need to match up with two little holes on the bottle. And that's what prevents you from putting that regulator on wrong or backwards or whatnot. Those two little pins, and I wish we had a picture, the two pins in the regulator need to make contact and go into the two holes on the valve. Is there a picture? Okay. Okay, so pressure regulators usually reduce it to 40 to 70 PSI. On the ambulances, it's about 50. Ambulances are regulated down to about 50 PSI of air coming out. So a flow meter is what's going to tell you how many, and these, how we measure these is in liters per minute. Okay, if you don't know that, write it down. This is how we measure the amount of oxygen that we're giving someone through our device is in liters per minute. And based on the device, you're going to turn these up or down, and we're going to go through those device by device. So it might either just be like a simple gauge where, you know, it's like a gauge you're used to. It might be just on the side of the regulator, there's a little notch and it'll say 0.5, 1, 2, 4, 6, 10. That's your liters per minute. Or in the ambulance, there's one, it looks like a tube with a little black ball in it. And based on where you crank that up, that ball will go up to those same lines, 2, 4, 6, 8, 15, 25. And that's where that ball's landing on that is the liters per minute that you're delivering out the oxygen delivery system. So the hazards, in theory, they are combustible and you could have oxygen toxicity. So in chat land, what is the oxygen percentage that the goal for our patients? What's the range? Do you guys remember? So what I'm saying is if they have less than this, we want to put them on supplemental oxygen. Yep, so 94. The goal is 94 to about 99%. If they're below 94, we need to put on supplemental oxygen. Okay, combustion, again, don't smoke around them. In your careers, it's amazing. There's people out there who are smoking while on a nasal cannula, and I've seen not one but two people who have blown their faces off and have had severe flash burns and stuff because they were smoking and they lit their oxygen on fire in their nasal cannula. So, Darwin Awards. Okay, oxygen toxicity. Again, not all patients need high concentrations of oxygen. If our patients are in that 94 to 96, that's great. Which, guys, this is kind of a change in thinking. When I went to paramedics or EMT school, the goal was to get them to 100%. Like every single person got a non-rebreather because it would just flood them with oxygen. And finally, we figured out that maybe we're giving them too much. That 94 is okay. We're realizing that a COPDer that lives at 88, maybe we just keep them at 88. That's where they're at all the time. We don't need to get them to 100%. In fact, getting them to 100% is oxygen toxicity for COPDers. What happens is, like we talked about, COPDers, really bad ones, have burnt out those receptors. They burn out the receptors in their medulla and their pons and whatnot, and they actually switch what they're reading. So in theory, after a long time, if you give them a bunch of oxygen, those receptors go, we're good. We don't need to breathe for a little bit because we have plenty of oxygen. And it's called switching to your hypoxic drive. But I think we're not going to see that on the ambulance. That's probably something that might happen if someone over-oxygenates them in a hospital stay. But it's something that could happen, and we can make them toxic.
I had a question. If they're 94%, but they're symptomatic,
We give them oxygen.
you get them off.
Give them oxygen, yep. Okay, you guys, we're gonna take a second. I put this graph in here. I don't know if it's in your book, but guys, write these down. These are very, very popular test questions. So here's the different types of oxygen delivery equipment. Nasal cannula, a simple mask, a non-rebreather, and then a bag valve mask. So you need to know at what liters per minute to operate these at, and you need to know about how much oxygen they will deliver.
Sorry. I've been clicking it since I died.
One thing you'll note there that a non-rebreather mask does not deliver 100% oxygen. Okay, it leaks, depending on if the vents are working right, if you guys use a non-rebreather mask, you have to take a second and fill the reservoir bag. That's how that works. You have to take your thumb, and we'll go over this later, but you have to press the little valve down. You have to inflate the bag. Kind of looks like a pilot's bag, like when they're, a jet fighter, kind of looks like something like that. But you have to fill that up before you put it on them, otherwise it doesn't work. And then you can see that the only thing that will deliver with a good seal 100% is a BVM that has a reservoir and that you're pumping a bunch of supplemental oxygen into it. But again, I've seen a lot of questions on state tests based on this graph right here. What's interesting, I have not seen a lot of ambulance services carry simple masks. Which,
I was just gonna ask.
no, I have not seen a lot, and we don't. A lot of patients get put on it in the hospital and the ER that we transfer out because they don't need a non-rebreather, like they don't need all of that, but they need just a little bit more than nasal cannula.
You're just talking about the regular.
Yeah,
mask with the hose that goes.
hose that comes in, it has big holes in it. It's just kind of it's coming in but it doesn't have a reservoir bag, but it's just giving them a little more supplemental oxygen.
We used to have a paramedic that used to get those all the time.
Yeah,
Paramedic 400.
yeah, because I think they're great. They're kind of a good in between maybe too much and then not enough.
Yeah.
Yeah. So Lauren brings up a good point. Okay. Like the non-rebreather mask, you guys, it has to operate at minimum of 10, but I'd recommend 12. Okay, it has to have so much liters per minute to work right. Like Lauren brings up, if you have someone on a non-rebreather, like don't have it at 4 or 6. That a non-rebreather has to operate at least 10, but personally, I'm gonna recommend that you put it to 12, if not 15. But it's a minimum of 10.
Well, if their demand is great that they're collapsing the bag, you want to turn it down.
Yep. Yep, that bag needs to be inflated. That's absolutely right. And then some other guys are pointing out here, you guys are going to see different equipment. Sometimes you got to work around different equipment. Some regular might go 10 right to 15. Some might have the 12. Very few have 13 or 14. With our oxygen regulars, it'll be like 10 to 15 or 10, 12, and 15. Just bump up to the higher one. Okay, so here's a non-rebreather mask if you haven't seen it. So these need to be fitted. There's a little piece of metal that goes over the nose. So you turn this on. Inside there where the hose comes in inside the mask, there's a little flapper valve. You need to take your finger, hold it over that until you see that bag fill up. You put it on your patient, you tighten the strap, and then you tighten the little nose thing. You want to try to have, it's going to leak, it's not a perfect seal, but you want them breathing in that as much of that oxygen that's going into that reservoir bag as possible. There's another mask that looks like this for nebulizers, where it looks like this, but some of the vents are gone and the bag's not there, but it has the hole that the neb treatment can go into. A trick, if you don't have one, is you can turn this into that. You can take that bag off, remove the two little flapper valves, and then a nebulizer treatment will fit into this, which is really handy if you have someone that you have to work on. So you're trying to get blood pressures, you're maybe stopping bleeding or getting an IV or whatnot. Now they don't have to sit there and hold that cigar looking thing. You can use one of these or a nebulizer mask and turn that into the neb, and then you have access to both their hands. And congratulations to the Wallowa. They said they just saved another life down there. So strong work. Again, make sure it's full. Like Patrick said, if they're breathing so hard, so fast that it's collapsing down, they're not getting the benefit of it. So you need to turn the pressure up, the liters per minute up on it. And then again, it kind of goes back to what Loring said. If you want to take this off and then turn the oxygen down, don't turn the oxygen off. Have them suck on an empty bag for a breath or two. Okay, because then it's called a non-rebreather, but then you're going to have them rebreathe stuff in. So if you're not using this to its full capacity, take it off of them. So here's a nasal cannula. So if you didn't write it down, you guys, a non-rebreather mask needs to run it at a minimum of 10 up to 15. The nasal cannula runs at 1 to 6. Do not run it. In fact, I don't typically go above 4 because you can like hear it whistling. It's a lot of pressure and oxygen. So 1 to 6 liters per minute for the nasal cannula. And it'll provide 24 to 44% of oxygen. How these are placed, to place properly, is the two prongs go in their nose, okay, around their ears, and it cinches up under their chin, around their neck. It does not go like you see in movies all the way around their head. Okay, it goes around their ears and back down in front of them. If we're going to be doing a transfer or whatnot, we can humidify it, which is basically putting like a bubbler up on the gauge, but typically we don't do that. We have the ability to. Some people with certain things it's very beneficial to if you have epiglottitis or something like that, because that air is very dry, it's filtered, and it can dry you out to the point that some people get nosebleeds. So if you're going to be in there a long time, it's a good maybe give them a little humidified oxygen. Sometimes people, like if they're all clogged up, they've had damage, or they just naturally breathe through their mouth. Nasal cannula is not the best choice because they're not going to be able to breathe that in. Okay, partial rebreathing mask. You don't see a lot of these. One-way valve between the mask and reservoir, but they will rebreathe a little bit of air. So here's a Venturi mask. Again, I haven't seen a lot of these, but based on the whatever probe or whatever adapter you put in there, it's going to use the Venturi principle to help deliver some oxygen. Like I said, I haven't seen a lot of these on an ambulance anywhere, but you want to be familiar with them. They're a medium flow device, so they're kind of, again, an in-betweener between a non-rebreather and a nasal cannula. So tracheostomy mask, so looks like an example of one there, kind of looks like a non-rebreather, but do I have a picture? It's basically a tube that is permanently placed, or a hole, a stoma that's placed in their trachea. Maybe they've had cancer, they have something going on, a trauma above them. Some people, if you're going to be intubated in an ER for a long time, or an ICU, like the tube intubation, it can be irritating, can cause damage, so they'll actually put in a trach if you're gonna have a long ICU stay. But just remember that that adapter there fits your BVM, it fits your other adjuncts. It'll be the same size. And then again, it's a small mask that maybe you can secure around their neck, and it's delivering high flow oxygen over that stoma. We've already talked about this. Some things like croup, someone or epiglottitis, someone might benefit from oxygen. If you don't have humidified oxygen, one trick you can do is just put saline in your nebulizer kit, because it's gonna aerosolize, and then as they're breathing that in or blow by, you're giving them a little bit of moisture with that blow by oxygen too. Great for kiddos that don't want something on their face. You can just do blow by, but if you put a little moisture or saline in there, it'll humidify it for you a little bit. Well, we have some people typing here.
I have a question,
Yeah.
off the wall question. Do they ask any questions on, which lever per minute on nasal cannula delivers what percentage?
I don't know if they'll get that deep, but you'll need to know it does 24 to 44.
Okay.
I know you'll have to know it to that level.
Then it goes 4% up until you hit 4.
Yeah, I don't know. I don't think they'll get that in depth. So you guys are time for another break. Come back. Let's do a little bit shorter. So come back at 10 after 8, please. So again, we'll take a break till 10 after 8. On chat land, let me know when you're back. Okay, let's move on. I looked, there's only about less than 40 slides left, so it'd be great if we could get through them and still get out of here a little bit early. So assisted and artificial ventilation, again, probably the most important skill at any level. Again, if your patient doesn't have an airway, whatever you do beyond that doesn't matter. And sometimes bagging people can be hard, getting that artificial airway, because they either have no teeth, they have a big old beard, they have some type of other abnormality or whatnot that it's hard to get a good seal. And it sucks when you're sitting there trying to bag them and you feel air like coming out of your fingers because you can't get a good seal. So being able to overcome those, troubleshoot it, and get artificial ventilation with a BVM is really important. So remember, on your state tests, okay, if the person is breathing less than 8 or over 28, you want to assist their breathing. That's I don't know. I've never, maybe with someone breathing less than 8, but just because someone's hyperventilating, I don't think I've ever tried to help them with a BVM. But it's on your test and it's something they recommend. So less than 8 or over 28. You need to have some type of answer or allude that you would assist them bagging with a BVM with those two numbers. So if someone's in a respiratory distress, you need to intervene quickly, like it says there, to prevent them from deteriorating even more. CPAP, PEEP, supplemental oxygen are all great things that you can do to try to intervene to help them oxygenate, help them ventilate. Signs and symptoms of inadequate ventilation. So altered mental status, inadequate minute volume. So minute volume is your respiratory rate times your tidal volume. So let's say they're only breathing in at 200 mils, which is about half of what they should, but they're still breathing at 20 times a minute. That's still inadequate. Or let's say they have a head injury, they're breathing very deep. Okay, so they're getting 500 tidal volume, but they're only breathing 6 times a minute. That's not adequate. So you have to look at both mechanisms, the rate and the depth for their ventilation. Because if one's off, their end result's still going to be low. And you guys, some people just get exhausted from breathing. We have the benefit as a paramedic that if we look at people and they just look exhausted, like they can't breathe anymore because they've expended all their energy, we have the ability to paralyze them and just take them completely out of the equation. This is one where you need to, they're only breathing 6 times a minute because they're done, they're exhausted. You guys will need to try to help them breathe with the BVM. Sometimes it's a little difficult because they'll want to swat that away from you, they don't like that. But after you're able to take over a couple of ventilations for them, they'll actually become more comfortable and let you do it. But the first couple, honestly, in real life gets difficult because people don't like, they're already having a hard time breathing. Now you're putting some over their face. So when you're assisting them and they're still trying to breathe on their own, so try to explain it to them. Be a good communicator. Say, hey, I'm going to try to help you breathe. You're going to feel this come over your face. Okay. Place it over their mouth. Squeeze the bag each time they breathe. Okay. So that you're trying to breathe with them. And then you're slowly going to take that over. They'll let you take it over. Okay. Artificial ventilation. This means you guys are artificially doing it. They don't have any respiratory effort. So they're in cardiac arrest, or they're otherwise dead or not breathing. Maybe it's an overdose, something like that. So you have to immediately start ventilating them. And in your test, like your state test, that when you do this station, when you go in there, you're going to walk in, they're going to say, patient's not breathing. Your statement needs to be, I'm going to immediately start ventilating this patient. And you can do mouth to mask. Okay, we're going to practice 1 or 2 person BVM. 2 person is better. Okay, the most effective way to ventilate someone is 2 person BVM. If you have small hands or there's those other things we talked about that makes it difficult to get a seal, it's really nice when someone can use 2 hands, do that jaw thrust or head tilt chin lift, and then 1 person just squeeze the bag. So the 2-person BVM is the most effective way to ventilate somebody. Okay, normal ventilation versus positive pressure. So positive pressure is you guys squeezing the bag. You guys are pushing air into the lungs. In normal breathing, like we've talked about, the diaphragm contracts, negative pressure is generated, atmospheric pressure pushes air in. In positive pressure, or if they're intubated or you guys have an eye gel or something in, you are forcing air in. That's positive pressure. And there's good and bad with both. Remember that you might not just be pushing air in. You know, if that BVM is dirty, or if you let it on the ground or something like that, that you're pushing stuff into someone, and you could introduce pathogens that causes like a pneumonia. So you want to try to keep that stuff clean. If they vomited and whatnot, don't lay your BVM down in the vomit next to their head. You can increase the interthoracic pressure, meaning like you fill those lungs up, and now they're actually pressing on those great vessels, pressing on the heart, and you can reduce their circulating blood volume a little bit. More volume is required, but again, remember that BVM is probably about 1,000 mils. A normal human adult is breathing in 400 to 600 mils. So if you were to squeeze that whole bag, when I'm going to get every milliliter into them, you're probably overventilating them. So about half the bag to see chest rise is what all you need. So Patrick mentioned this earlier. There's 2 things that cause gastric distension when you're bagging someone, and you really don't want to do it. Okay, 2 things that prevent gastric distension is you want to have a good rate, okay, with a good amount of pressure. So if you're squeezing the bag too fast or too hard, you're going to force air down into the esophagus and then the stomach, or if you have poor positioning. So you want to have good positioning and a good rate and pressure, because you don't want air to go into the stomach. 2 things that'll happen if air goes in the stomach is, 1, you're going to find out what they had left to eat. The other thing too is the stomach can be like a balloon, and that'll just fill up, and you can actually cause it to pressure back up onto the diaphragm and maybe even into the lungs because you overinflated it. And you can see when someone does poor bagging on like a cardiac arrest, you can literally sit there and see their entire gastric area, their stomach get bigger, and you can see it grow. And then you're at the end, and everyone kind of stops and looks and goes, "Holy cow, is his belly that big when we started this?" And because sometimes they can get huge by improper bagging. So proper pressure and rate, and then good positioning to prevent gastric distension. Mouth to mouth, mouth to mask. Okay, you guys, we are not going to recommend mouth to mouth. We are not going to teach it in EMT class. You guys are EMTs. You should be using a barrier device. In fact, OSHA, if you guys are working for the ambulance, you cannot do mouth to mouth. We provide barrier devices, and you have to use those. You can do mouth to mouth on a family member out in the community or something later. While you're working, while you're on an ambulance, do not do mouth to mouth. And then sometimes both of these, they have a little port that you can put supplemental oxygen into if you're doing with a mask. Okay, so let's say you're doing a good job. Okay, so all the things that made you go, "Man, I got to bag this guy," hopefully they're starting to improve. And this is something you want to look for and something you want to document. Their color improves. So all of a sudden they're kind of pink again. They're not blue and pale. They have good chest rise. There's no resistance. So when you're bagging, there's a word that we use or talk about with how good they're bagging, and it's called compliance. So compliance is when you squeeze that bag, does it go in easily? Versus you squeeze the bag and it feels like there's a lot of resistance, there's noise, it's just not going well like you'd expect it to. That would be poor compliance versus good compliance. And that's how we describe bagging somebody. And that changes because you can be bagging someone and have good compliance, but then let's say they go into flash edema and they fill their lungs up with fluid. All of a sudden your compliance might go poor within a couple of breaths. And that's something we want to be talking about. Like if we're having to bag somebody, we'll ask that. "Hey, Valerie, what's compliance like?" And if you're sitting there squeezing good, you can say like, "Oh, compliance is good." versus if something happens later. And that's just a way to keep track of how your bagging's going. Okay, so there's a BVM. Okay, most commonly used method in the field. And if you get good with this, you should be able to try to bag by yourself, but most of the time, we want to try to do it with 2 people. It's just way more efficient. Again, if you have small hands or there's a beard or they don't have dentures, it's really hard to get a seal. So here, I threw these in here. This is kind of a busy slide, but let's look up there in the upper left-hand corner, the guy with the white shirt. So this is called the CE method, okay? The CE method where you are holding, the 2-person is holding your big finger, ring finger, pinky finger make an E, and then you have a C that's holding the mask. And then the idea is that your pinky can raise up that jaw, okay? The best way to do it is to use 2 hands. So your pinky or your ring and pinky are doing the jaw thrust, or you're doing the head tilt chin lift, and those other fingers are holding the mask gently to the face. If you can't get a seal, the solution is not to just press that mask harder to the face. You need to look at instruction or your positioning. You should just be able to hold it relatively firm, but not press it to their face. So up in the corner there, the guy with the pink gloves, that would be the example of the CE method with 1 hand. Below is another technique they're teaching, which is kind of the 2 thumbs towards the toes. I don't know what they call it. But here you can see they can get a good jaw thrust. They can hold C-spine if necessary, and they're still holding that mask down to the face. That so the 2 upper BVMs, those are ambu bags. Though you can see that those don't have PEEP valves. The pink one, and then I have an example of a PEEP valve that replaces your exhalation little port. And that's, if you have a good seal, that's what's going to give you some PEEP. That's going to allow those alveoli to stay open. And it just cranks. It goes 0. You crank a little bit, it says 5, 10. I think they go to 20. But you just crank it down like it shows there. Okay, if you have difficulty breathing, then try another method. Or, okay, make sure there's not an obstruction. Make sure you have a good seal. Try to get some help. Like, you got to troubleshoot if stuff's not going right. Again, the volume is based on, you want to see just a little bit of chest rise and fall. Not a lot. You don't want to overinflate, but you just want to see that they are rising a little bit. So it's something you might have to do is you got to get down to look at skin, or at least a t-shirt. Someone's wearing a big coat or something like that, you're not going to be able to see chest rise. Gastric distension, we've already talked about this. Don't put air into the belly. Okay, so good positioning, the right rate, and right pressure and volume. And if you do have gastric distension, be prepared for them to throw up on you. Passive ventilation, expansion and contraction create a pump for air movement. Benefits who are receiving chest compression. So with this is you have a BVM, and rather than stop like you're 30 and 2, you're as that chest person's rising off the chest, okay, you're getting air into them. You're doing a ventilation there, which is nice because you're not stopping every 30 and 2 to give 2 breaths. If you're good at it, a good team, you guys can just continue to give supplemental oxygen. While you're doing chest compressions, and limit the pauses. There's some devices out there where it's like a pressure, like a little trigger, where you put it on them and you hit it, and the pressure of the system ventilates them. Some ambulances have them. I've never worked on an ambulance that has them, but basically it's just a pressure device that you're hitting and it's delivering oxygen. And again, most places don't use these because it's pretty easy to overinflate, overpressurize people with them. They can be dangerous. Ventilators, you guys will never have to use a ventilator. In Oregon, you're not allowed to even touch them, monitor them, put them on, anything like that. But you guys might run into, you guys get called out to a kid that has a congenital disease or whatnot that's on a home ventilator, and you might need to transport them in with it. That you just need to bring mom or dad. They will be the experts in that. Here on the ambulance, like if we have a cardiac arrest or we RSI someone, you might have to help us because the couple of paramedics can use them, put them on them, but it's just going to be your role in that will just like be handing the tube or watching it, stuff like that. Again, the EMT basic level, especially in Oregon, you're not allowed to touch these. So, but what's nice, if they are on there, you freed up 1 or 2 people because this is doing the ventilating for them. And you get a lot of good data from them. You know, because it tells you by the mill how much air is going in and out, what the pressure is, all that, if you have the right type of ventilator. Okay, so here is CPAP. This is a skill that you guys can do in Oregon because it's just applying oxygen under some pressure or back pressure. How these systems work like this, and I have a picture of another one, is you put it on, relatively tight fitting, you don't want any leaks, and you just turn your gauge up. So it might say, if you turn it to 15 liters, it's providing 10 of CPAP of back pressure back, depending on what type of device you have. If people are not on these regularly or have never been on one, sometimes it can be difficult to get these on them. They don't like them. But if you can get them to breathe 4, 6, 8 times and they get used to that, they get the oxygenation from it, they'll begin to accept it and to like it. But honestly, to get people to do it initially can be difficult sometimes. But what you're doing here is you're providing PEEP. You're providing a little bit of back pressure to keep those alveoli open. And a lot of people wear these at night because if they have sleep apnea. So again, what it does, it just gives a little back pressure, opens the collapsed alveoli. And then if there's fluid, even like in a pneumonia or CHF, it can actually help push some of that fluid back out and pop open this alveoli, and it can push the fluid back away from that, which is very beneficial. This is one of the first things we want to do to someone that is like in CHF, they have fluid building up in their lungs. This is one of the first things we want to try to do, is to pop those alveoli back open. You want to use it in patients with low blood pressure because you remember how we talked about earlier where we can increase intrathoracic pressure. We can inflate those lungs and do all that actually squeezes down on the heart and the vessels. This can do that too. This can provide intrathoracic pressure, and it can lower blood pressure and hurt your circulatory system. So when to put this on, guys, people have to be able to breathe on their own. This isn't something that you put on if someone's not breathing or not breathing very well. They have to be conscious. They have to be able to clear their airway to wear this. Okay, contraindications, you guys want to write these down? Okay, these are times when you do not put CPAP on people. Respiratory arrest, we don't want to put it on chest trauma or pneumothorax because we are providing pressure to the chest. So we don't want that air that should be coming back out to go out that hole in the lungs and go into the chest cavity. Okay, not for someone who's had a trach. No GI bleeding or vomiting. We don't want them vomiting back up into that mask. And if they can't control their airway or follow commands, they're too obtunded, they're too sleepy, whatever, then we cannot put them on this. It's someone who's in distress, but can follow commands and breathe on their own. And again, like it says there, depending on how many liters per minute you have going through it, it's going to provide 7 to 10 of PEEP or centimeters of water is how it's measured. But that's the range we're looking for, is about 7 to 10. So you just need to look at your device put up the flow rate of the liters per minute, and it'll tell you at this flow rate, you will get this much centimeters of water of PEEP. And then there's an example of another one. This one is nice because it has a neb treatment in it. And when they have a neb treatment, they have a little spring. So that way, when they breathe in, it activates that spring and they're getting that nebulizer medicine in under pressure, which is going to get that medicine down in there farther. But this is again like a flow safe. And then complications, like it says there, I would say almost all patients that if they've never had one on before, they don't like putting it on. And you need to really try to coach them and help them out. One technique is just let them hold it, okay, until they get used to it and then start tightening it down. But if you think about it, remember PEEP, and like some of the videos showed, if you have that on there and you start making tracks, like you start getting PEEP, you start getting alveoli popping open, they're doing better. What do you think is going to happen if you take that off? You de-recruited, you lost all those alveoli you just popped open. So once it's on there, we really try to keep it on there. Otherwise, you're going to lose everything you gained. And then you might need to take it off and start managing their airway. Some people just doesn't help them recover. Okay, some people have a stoma. They have a permanent hole there in their trachea that they manage. Complications I've seen with these are people are cleaning them out and their Q-tip or whatever falls down in there and they have trouble getting it back out. But sometimes people take these out and they clean them and whatnot because they don't want them to become infected. So there's kind of an example of what the commercial device you might see that's intact. And it just looks like a little plastic curve that they just slip into their trachea here and they just stabilize it down. Some people might have this, like this kiddo, so he can still talk or eat, do stuff like that. They put these trachs in, and then he might be assisted by a ventilator or some other type of CPAP or something like that. They'll just put the tube right to it, so he still has function maybe of his mouth and in those structures. Okay, again, you don't want to do any of those maneuvers. You can bag them through that trach device. That right there is the same size as an ET tube. It's the same size as your iGels, your King Airways. Your BVM will fit right on that. They're all the same size. And let's say like you guys saw the picture where there's just like the skin flap, the hole, but that tube's not in there. You're not allowed at the basic level to put that tube back in. So if they need supplemental oxygen, just put like a kid's mask or something over that. And that's how they'll breathe in there. Okay, foreign body. Okay, an adult usually occurs during a meal, so they got that hot dog, hamburger, whatever stuck in there. Really common with dementia patients or dementia patients who are advanced, because one of the digressions of that disease is that you forget how to swallow. You forget how to do, your body forgets its airway management. In kiddos love sticking stuff in their mouth. Legos, food, rocks, whatever. Again, the tongue is the most common foreign body airway obstruction, so you need to do positioning, whether it's head tilt, chin lift, or jaw thrust to remove the tongue. And if you have to, put in your adjuncts, your OPA, NPA, your King Airway, or your iGel, which we'll go over later. Swelling. So if a kid might have epiglottitis where his epiglottis is inflamed, it's swelling, it's sore, maybe other allergic reactions, things like that, that's causing that back airway to swell. Early recognition is crucial. So remember, someone like in your CPR class, if someone can talk, cough, whisper, you don't really want to do a lot. Let them try to cough and clear that out. It's when all of a sudden they stop breathing or you just have those little squeaks, wheezing that we might need to intervene. And they just have it broke down between so mild, and then a severe airway obstruction. Here, this guy is choking, kind of doing the universal choking sign. Here, you might need to do, like, they used to call it the Heimlich maneuver. We're doing abdominal thrust on him. Try to get that out. And you do that until either the object comes out or they go unconscious. If they go unconscious, you just kind of go into your CPR stuff, because hopefully your chest compressions, bagging, that you'll get some air past it, you're getting perfusion, and maybe the chest compressions will pop that item out. If you can see it in adult, maybe use your gloved hand and sweep it out. Use suctioning. In a kiddo, or if you don't see the object, don't put your finger in there, because you'll probably just push it down farther. And again, like it says there, do your abdominal thrust, do your Heimlich maneuver to try to clear it. Okay, some other stuff can get in the way if it comes loose. Broken teeth, dentures, pieces of braces. If these get in the way of your ventilation, you just get them out of the way. If dentures are intact, you guys will remember this. If dentures are intact and in place, leave them there, because they're giving structure to the mouth and to the lips and whatnot, and it'll help you get a good seal. Only remove dentures if they're falling out or they're falling in the back of the throat. But if they're in place and secure, leave them there. Okay, facial bleeding. Remember, the head bleeds a lot. It can be kind of scary, especially for the layperson, to understand that. A little laceration anywhere on the head can look like a lot of bleeding compared to other places in the body, because the body's just trying to do everything it can to get blood to the brain. So it's very vasculature. But mouth injuries, face injuries can bleed a lot. So you just got to be really aggressive with your suctioning, your positioning. If someone's bleeding into their mouth and airway, we probably don't want to lay them supine unless we can suction them really, really well. Okay. That is it for tonight. Like I said, get you on a little early. We made it all the way through. Next class, I think next Wednesday, will be pharmacology. And we're going to go over the principles of pharmacology, but then we're going to try to introduce you guys to all of the drugs that you can give as an EMT basic. The indications, dosages, all of that. Please try to get your study guides done. And I will send you out either in a packet or an email some study guide stuff of everything, probably from chapter 1 all the way up through this chapter, that you guys can carry on at least through the end of the year. But yeah, so I think class is next Monday, right? Okay, so have a good Thanksgiving. We'll see you guys next Monday.
That's pharmacology.
It'll be pharmacology, I think, is the next class. Yeah, principles of pharmacology. So thank you.
Want your pen back?
Sure.
I'm throwing it.